Thanks so much for having me here. It's really an honor. It's just been an incredibly distinguished panel and feel a little out of place, but very excited to share some of my experience with Connectomics and I think also on the heels of some of these powerful technical talks that we were just privy to. I'm hoping that in some ways that what I talk about here will kind of democratize the technology, if you will, and make it seem a little bit accessible. And I think a lot of my experience with the software and some of the cases I talk about will help to do that. Well, those are my disclosures. So again, just to go over what I want to touch upon in this talk. So I want to dig into some of the practical applications of applying the burgeoning interest and knowledge that has come from the Human Connectome project and has manifested in particular in the omniscient brain mapping software known as QuickTome. I want to go over some of what may be less familiar to those of you in the audience, some of the non-canonical brain networks that have really only recently kind of risen to prominence and recognition, thanks to much of the work done in the Human Connectome project. And then I think probably what will be most useful today will be the cases that I have here to present about how the technology has impacted my own approach to brain tumor surgery. So we'll start with personalized brain maps. So the concept of redefining eloquence, I think it's a bit surprising to take the step back that this requires. And when you look at kind of how neuroanatomical knowledge has advanced, it's been fairly static for a long period of time. And to some degree, that's a credit to the innovations of Brodmann and the cytoarchitectural atlas. But when you look at the date associated with that atlas, it's pretty incredible that that's really been the standard for neurosurgeons and neurosurgical understanding of eloquence and cortical regions for a very long period of time. And you've seen much in Dr. Kassam's talk in particular about the innovations in tractography and understanding white matter bundles. And much of that really, I think, peaked with the Human Connectome project, the atlas that was published in 2016, which was trained on over 1,000 healthy volunteers undergoing MRIs with DTI and interpreting that there are not just the 52 areas that Brodmann described, but that there are actually 180 areas of cytoarchitectural significance in both hemispheres. So that was a significant jump, obviously, and almost certainly there will be further subclassification and parcellation that will even increase those areas as technology improves. But that was obviously a major step. And so what that's enabled us now is to hone in more and move away from the traditional localizationist view of eloquence, Broca's, Wernicke's, the arcuate fasciculus, and that's your language system, to a much more refined or redefined sense of what eloquence consists of. This is my own phrase is extreme eloquence, just the notion that the brain is not limited to a few areas of eloquent terrain, but that as we understand much more about where these networks are located, that much more of the brain is eloquent than we had given it credit for. So going beyond the task-based fMRI and the personalized brain map, so talking specifically about the QuickTome software. So this is software that's based on the Human Connectome project. And the power of this software in particular is that it identifies networks that go beyond the capabilities of MRI, task-based fMRI, and awareness and knowledge of these networks should help to inform and enhance our approach to brain tumor surgery. So this concept of respecting networks and not simply resecting. the software is able to generate individualized tractography. So this is all personalized. Every patient undergoes, as part of their basic MRI, undergoes DTI imaging that is then loaded into the software. And the way the software works, and admittedly, this is a bit of a crass overview because there's a lot of technological nuance that goes into this. But there's a machine-based algorithm that has trained on the Human Connectome project. And so based on the knowledge that this algorithm has obtained by being trained on the Human Connectome project, it knows where to connect the DTI dots, if you will. So when your patient's DTI images are then taken by the software and overlaid on what the Human Connectome Project atlas is, the dots are then connected for you. And then you're just basically clicking on networks, and those networks are displaying on that patient's MRI. So that's how I've oversimplified it there at the bottom. So talking about brain networks, so this is what we would consider the traditional curriculum, what are considered the canonical networks. That is obviously extremely familiar to anyone doing any type of brain surgery: sensory motor, the visual network, limbic, which of course is a network and something that we may be a little bit more or less mindful of, if you will, and language, which is asterisk there because it's technically considered actually a sub-network because of the way it integrates into other networks. But now what we have before us is what we've basically titled a new curriculum, what are considered the non-canonical networks. And so again, the two incredible talks that we had before this really dug into tractography and the white matter bundles. But this is these are those bundles writ large, if you will. This is where Connectomics really steps onto the scene, and where you see these white matter bundles contributing to the connectome, to these networks. And in particular, what we would call these non-canonical networks that probably a good percentage of you in this room are less familiar with. And frankly, even as someone who's been using this software and trying to improve my awareness of these networks, I can not remotely consider myself any type of expert in this. I remain very much in the mode of learning and respecting and making sure that I am optimizing my approaches to these tumors by doing my best to respect these networks and not injuring them at surgery. And so you see, these are all networks that have a tremendous amount of literature behind them and really provide some of the functions that I think we as neurosurgeons may gloss over. And I'll talk a little bit about that concept in the next couple of slides. So when it comes to postoperative deficits following brain tumor surgery, I think we've been programmed through our training to really only consider some of the obvious gross deficits and explain those through some fairly obvious mechanisms such as ischemia and stroke. So, and that's what I have here on the bottom left. So we have these gross deficits that occur after surgery: hemiplegia, aphasia, hemianopsia. And typically those can be explained fairly easily, even if it may be hard for us to admit that we made some type of error and caused some type of damage. But what I think the kind of newer age of understanding the connectome and these networks leads us to is developing a better understanding for why patients have more nuanced deficits. So, why is a patient good, not great? Why can't a patient return to work? And I think that a lot of times as neurosurgeons, we've been conditioned to be content when we get a patient through a major operation to have a patient show us their thumb or say that we're showing two fingers or maybe telling us who the president is. But in reality, we know that that assessment is incredibly clipped and falls well short of being of assessing whether or not this patient is going to get back to a high level of function. Now, of course, we've had talks here throughout this conference, but this is obviously a concentrated group of real special neurosurgeons who are considering using or actually deploying neuropsychologists and performing neurocognitive testing, but that is not routine. So I think the goal behind democratizing software like this or democratizing this information is to make this more routine, kind of holding the field up to a higher standard. So when we get into explaining some postoperative conditions, we'll sometimes shrug it off and say, well, here's why this patient might have a deficit. We retracted and there's inflammation or there's manipulation of the brain. And that tends to be a little bit of a throwaway excuse. That's kind of an elephant in the room. It's often difficult for us to admit that there's ischemia or infarction, but is there something less obvious, right? And that's where, again, that's where I think really Connectomics comes into play. That's where these non-canonical networks and a consideration for higher order cognitive function comes into play. And so therefore, I think that there's a kind of a developing onus on us, if you will, to be more cognizant and aware of these networks. And that's why in the top right there, I think we now as a field are, and I think that this is kind of an inspiring call to arms, that this is, we have a higher standard of care before us. This is not a time where it's just getting the tumor out and adding survival, but we and our patients are expecting more. And this is of a piece with that mission. And of course, underlying all this is this concept of oncofunctional balance, right? We want to remove as much tumor as possible to prolong survival, but we don't want to do that at the cost of causing a functional deficit. So that's always shot through our decision-making when it comes to brain tumor surgery. So there are a few papers out there specifically looking at these non-canonical networks and essentially demonstrating why they're important. And so you can see that in this review, that there are significant deficits, these cognitive deficits that I've been speaking about, associated with injury to non-canonical networks. And so that's, so it's not just, it makes sense that if you damage one of these networks, that there may be disorders in cognitive processing. But there's actually literature to support that as well. And this is a study that came out of the University of Miami group using the specific software that I'm discussing today, showing, again, deficits associated with injury to non-canonical networks. And in fact, not just injury, but in fact, even before surgery. If patients are getting neurocognitive evaluations before surgery related to tumors in specific areas of the brain that cause cognitive dysfunction from impacting these networks. So I'm going to jump now into some case examples, and I always talk about this case. This is really a favorite case of mine because this is really what showed me that there were significant limitations in my understanding of how the brain works. So this was a case that I did. This was before I was using anything connectomic based or had any sense that even existed. So this is a 25-year-old who presented with occasional right hand and face twitching, clearly focal motor seizures, had this flare abnormality that appeared one gyrus anterior to the hand motor cortex. And I did a functional MRI, a task-based fMRI for this, which I think most would do. And you could see that those areas of red correlate to the finger tapping, and you could see them bilaterally represented. And then you could see where the tumor is, and on either side of the tumor, and particularly a bit lateral to it, you see that there is word generation there. And I remember seeing this functional MRI result, and I was shocked by this. And I'm very open about, there may be someone in the room who thinks that may understand immediately why that's the case. But this is 2018, and I had no idea why that was the case. And I remember clearly running this by our neuroradiologist and other colleagues of mine in neurosurgery, and including our neuropsychologist. We just didn't have a good explanation for why there was a language area right there. So what I ultimately did for this patient was I called her and I said, instead of us doing this as an asleep surgery, and I was doing motor surgery or peri-eloquent or perimotor lesions asleep at that time, and I still do. But because language was so close to that lesion, I felt obligated to do this as an awake surgery. So we did this as an awake operation, and we had reproducible speech arrests on either side of the gyrus containing this tumor. And there was an obvious correlation to what the functional MRI had shown. And I had no real explanation for this until I ultimately presented this case because I found it so fascinating at a Connectomics seminar with Mike Shagru, and he pointed out immediately that the area that was responsible for language here was area 55B. And I had no idea what area 55B was. And so I realized that area 55B was described in the Human Connectome Project. and that it may be wired to or part of the laryngeal motor cortex and the posterior aspect of the middle frontal gyrus. And it's a little bit more complex than what I've depicted on this slide. But the moral is that I was unaware of an expressive language area, and then my awareness of that area helped guide that operation. Now, I probably would have done a very similar surgery, but perhaps I would have been a little bit more liberal. And again, that's a trend I'll talk about a little bit too. In a young patient with a low grade, maybe I would have been a little bit more liberal, going deeper or lateral to it, perhaps. Hard to say exactly how I would have felt. I obviously would have been very careful posterior because of the proximity to the motor cortex. So that was basically my entry into the world of connectomics, because I felt at that point that this was a significant lack in my personal understanding, and I felt obligated to understand this in more detail. And that's why I became a very early adopter, in particular, of QuickTome and this connectomic-based approach to surgery and preoperative planning. So this is one of the first cases I did using the software. It's a 74-year-old progressive aphasia. It looks like an obvious glioblastoma. And I show here a couple slices from QuickTome before and after the operation. And I have a blue arrow here pointing to a concentration of fibers comprising the superior longitudinal fasciculus running right along the medial aspect of that tumor. There also are some parcellations that you can see within the mass, and that will spark a whole other discussion. I don't know, I can't tell you it has impacted the operation here in a major fashion, but I can tell you that, as many of us in the room would be, I was quite careful along that deep border of the tumor. And I also stimulated the cortical surface and found no change in her language function. So I was a bit, therefore, emboldened to remove some of what those parcellations were that the software was finding within the tumor itself. I did a postoperative QuickTome, which I now do pretty routinely, and you could see, though the fibers are attenuated, that they're preserved. And then, of course, this has in general occasioned the more rigorous utilization of pre and postoperative speech therapy for evaluations. And this patient did well on the speech evaluations before and after. She was compromised, but I should say she was not impacted negatively by the operation. This is another case I have with really a flare dominant, ultimately non-contrast enhancing, but ultimately IDH wild type, and therefore a grade 4 astrocytoma. And we performed this as an awake operation, and I utilized this case because as we were getting to the anterior and superior portion of this mass, which was near the parcellations that you could see on the left slice there, the left half of the slide, that we were clearly getting into, or very close to, some important language function, and the patient did develop paraphasic errors during the operation, which then persisted after surgery. And so we did a QuickTome after the operation, and lo and behold, you could see that blue arrow, which is not labeled SLF, pointing to an area that appears emptied out of parcellations and arcing fibers. So it definitely looks like, in that particular case, that there was injury, there was damage caused to these fibers. I had not adequately preserved them, and a deficit followed. A deficit, albeit that ultimately improved, as many of these deficits do. And at the bottom there, I say, does the improvement correlate to fiber and parcellation reconstitution and QuickTome? And unfortunately, I don't have enough of the follow-up images long-term, months down the road, to see how rewiring occurs, or where the parcel, or what is occurring, if anything's being supplemented from the contralateral hemisphere, for example. This is a 45-year-old who came in with significant personality changes, odd behavior. This looks like a GBM. It ended up being a high-grade oligo. And I did a QuickTome on this patient, and this is a case where you can see the default mode network is this node of the default mode network is largely contained within the mass. So this is a case where you might have many neurosurgeons saying, well, is this too much information? You know, I just want to rip this thing out, right? I mean, can I just do a lobectomy like I normally would do? And ultimately, in this case, that's what I did. And you know, I just made the determination that no meaningful resection could be achieved without sacrificing that node of the DMN. So was knowing DMN is contained in this lesion helpful? Was it too much information? What were the clinical implications of even taking this node, right? The default mode network is responsible for internal thinking, imaginative thoughts, and processing. How do we even really assess something like that in a patient? How do we assess someone's imagination? It's not easy to do. This is a more recent case where, in contradistinction to the prior case, where we did more of what would be considered a traditional lobectomy, this is what I would consider more of a restrained lobectomy. And the question is, why would we be restrained? Assuming this is an astrocytoma, let's just say, why would we be restrained in this, right? Are we being now told to be supramaximal, especially in young patients, in a right frontal location? So this is the quick tome that we did pre-surgery, and we could see as this rotates the three-dimensional projection that just lateral to the tumor is a central executive network. So that gave me some pause in a young, high-functioning person. It gave me some pause about whether or not I should extend the lobectomy to the traditional lateral borders that such a removal would mandate. And so ultimately what I did in that case was I did not take that lateral aspect, and maybe someone in this room would automatically, maybe not. It's an interesting discussion independent of connectomic information in and of itself. But I think it's an interesting discussion, especially as I just mentioned, with the push now for these supramaximal removals. Also, in this particular case, there was some callosal involvement, which was an additional deterrent because a true gross total or even supramaximal was not really achievable, in my opinion. And you can see on the postoperative quick tome, so we have a 3D displayed here as well, that the central executive network is preserved. Now, of course, we don't have two of these patients, one who gets the full lobectomy and one who gets the restrained lobectomy, and we can compare their neurocognitive functionality after those two operations. But I would like to think that preserving the central executive network allowed a high-functioning recovery for this person who's back to work. This is a last case, and it's more in the spirit of this meeting on how some of the connectomic information helped with trajectory planning. This is a deep-seated location of a metastasis, and some consideration obviously paid towards the more traditional sense of doing this through a short trajectory, just a transsulcal approach using a tubular retractor system. But as you can see here on the quick tome, that there are quite a few fibers of the superior longitudinal fasciculus just running right along the lateral edge of that tumor, which would make accessing it through that short reach potentially injurious to those fibers. So ultimately, we chose a sulcus of interest below and medial to the superior longitudinal fasciculus here. And you could see that this was the intraoperative setup, and this is how we aligned our navigation.
Time.
Yep. And this was the ultimate result. So I probably, in a talk like this, raise more questions than we necessarily provide answers. And I just want to leave you with the fact that this is something that I've now integrated into my practice essentially for every operation that I'm doing, every operation for an intraaxial tumor, I should say. And there's significant promise, I think, even beyond this, and Dr. Bangu touched on this in his talk as well, with using navigated TMS, both preoperatively and postoperatively for recovery. And hope that you guys got a sense of how this has become practically applied in my day-to-day, and thanks so much.
Thank you, Dr. Hanft. Great talk, great work. We got time for one question. Go ahead.
Thank you for your talk.
Thank you.
I have a question. In your opinion, mostly I'm asking for a comment. What do you think? You said that you cannot do a lobectomy blindly anymore because of the connectomics, and that's fine. Do you think, or do you know if there is any data that we can corroborate, we can work on even later, comparing the awake findings with connectome sparing surgeries? What I'm saying, you can spare on an image-based part of a network, but we all know that the functional preservation might even go beyond preservation of one network, or part of a network can be compensated somewhere else. That's something that when you do awake, you get a negative test, so you can go on and you do a subcortical resection. What's your what's your opinion? You preserve the connectome on imaging base, but what's the next step, for assessing the neuropsychological functioning?
Yeah, I'll try. It's a great question. I'll try to tackle it quickly from a few angles. So first of all, there are still times, and I have that case where I will do a broad lobectomy. It's not an immediate rule out based on connectomics. I'm just a little bit more careful about it now. We can, I think fundamentally some awake testing is limited for some of these non-canonical networks. I mean, I often kind of make this quasi joke that a lot of our intraoperative testing is if we're showing, an executive a picture of a cow and they say this is a cow, that is often adequate for us intraoperatively to think that we're not injuring a network. But to test the higher order cognitive function is challenging. But I can also tell you that testing awake and testing language function intraoperatively correlates well to what the networks are showing. So, but yeah, I think fundamentally testing some of these networks is very challenging intraoperatively.
Okay, thank you. Great presentation.